Top Med Talk.
Well, hello, I'm Desiree Chappell, and this is Top Med Talk. I'm here in Orlando, Florida for SPOCI, 14th Annual Perioperative Medicine Summit. SPOCI is a Society of Perioperative Assessment and Quality Improvement, and the Perioperative Summit is the Society's annual international multidisciplinary meeting. We're wrapping things up today. The meeting just finished. I'm joined here with Monty Mythen, Editor-in-Chief. Hello, Monty.
Hey, Desiree. It's great to be here. I know the meeting's nearly finished because guess what's happened?
The sun has gone away and it's cloudy. And
it's about to rain.
It's about to rain. We said we're getting ready to head out to the pool.
It is February after all.
It is. So we've had the opportunity here at the meeting to sit down with some great speakers, presenters, delegates, and hear about how wonderful the meeting's been. We now have the opportunity to sit down with another special guest, one of the speakers here, Dr. Houman Javedan, who is a geriatrician from the Brigham. So thank you so much for joining us.
Pleasure.
We're finishing things up, so if I stumble through my words, we're
fine.
tired. But can you give us a little bit about your background, a little bit more about your title?
I'm clinical director of Geriatric Medicine for the Division of Aging at Brigham Women and assistant professor of medicine at Harvard Medical School. I'm a geriatrician. I've basically, in the last 5 or 6 years, developed a lot of the geriatric co-management programs at the Brigham, initially with the orthopedic trauma service, and then working with other colleagues to expanding it to general trauma, oncology, thoracic surgery, even primary care, and very soon going to be expanding into, hopefully, general medicine and other areas.
Wow, you've been hard at work.
Can I take you back a little bit further in your history? I think we first met, you mentioned about your initial training.
Yes.
Secret.
We
were discussing the wall earlier.
That's right. I'm actually one of these world citizens in many ways. It's interesting. I actually... I grew up in Ecuador, actually, interestingly. I went to school, and then I was one of the first people to go from Ecuador to Harvard undergraduate for my undergraduate degree. And then after that, I went to Edinburgh Medical School.
Oh my gosh.
And that's where I did my medicine. And I started my surgical training, actually, at Royal Infirmary of Edinburgh, and then at Glasgow Royal Infirmary.
That would have cured you.
They're
busy places, very wonderful institutions, but they're busy.
I've openly said that Edinburgh Medical School is really my academic heart and center in many ways. I think that's where I truly learned what it meant to be a doctor in my medicine. But after that, actually, I was very interested in the older surgical patients. I was the troublesome house officer, really, that kept questioning why we did things the way we did them. And actually, I also owe it a lot to the geriatricians in medical school in Edinburgh, who were the first to kind of plant that seed of aging, and the physiology of aging changes things. And you need to keep that in mind. So one of my mentors actually said, well, if you're interested in these older surgical patients, why don't you do something about it? And I was like, well, all right then. And to his shock and horror, I said, well, if I've got to do geriatrics, I've got to go do medicine now. So I decided I had to actually cross the pond back to the States, ended up coming back here, did my internal medicine training and then my geriatric fellowship training, and then started kind of co-managing these surgical patients that were older, and that's where we are now, where we've kind of evolved through the phases, and I think geriatrics has also evolved and kind of gotten involved with some of the frailty work and perioperative co-management of older surgical patients.
Yeah, and as you're saying, it's a boom area. I mean,
the Silver Tsunami.
Yeah, which is, as a silver person myself.
But you've been silver-haired for a long time.
But it's also, I mean, people in the past may have shied away from being a geriatrician, a care of the elderly doctor, but combined, if you're a bit more towards the sort of surgery, anesthesia, flashbang end of things, combining it with the perioperative challenge, I just think we've talked a lot about this on Top Med Talk. It's a very interesting area. Yeah. It's a really interesting area. So I think any young person out there listening, it's a great opportunity, and it's unlikely that the robots are going to take over soon, which in many of the specialities, the computers and the robots are taking over soon. So. I
completely, if anything, if you're listening out there, that's one of the things that I do most is to dispel the myth that geriatrics is a dead end.
Yeah.
It's actually the opposite, because if you actually see the patients where a lot of the thinking and complexity is not optional, is required, is in geriatrics. So in many ways, if you are interested in medicine because you truly love the core of medicine, which is the ability to to think things through and implement them and take every human being and evaluate them for who they are, I think geriatrics is definitely the field for you. If you like kind of repetitive, simple stuff, kind of the kind of interventional ones that are just repetitive and high yield and whatever, then it's not for you. I agree. But if you like complexity and uncertainty, but the difference also is it's also an area where, due to the demands of the physiology of our patients, I think the impact we have can be quite large and that's what a lot of our outcomes have shown. I mean, the reason you're talking to me is because our co-management programs have made a huge difference in the outcomes of our patients.
Yeah. Well, so, I mean, you were talking about frailty specifically quite a bit during the presentation here, and we do talk a lot about it on Top Med Talk, and one of the things I found really fascinating about what you were saying was that, a lot of people think, well, chronologically, they're elderly, they must have all the other problems, they're going to be frail, and I can tell. So you gave a figure of surgeons, rate of being able to determine frailty.
The old kind of teaching was you can eyeball it.
Yeah.
You can eyeball it. And everybody...
The handshake.
You give them, and the truth is because, if they had one 90-year-old patient or even maybe 4 80-year-old patients, but... The problem is, in the Silver Tsunami, I think this is the one comment I said to people, is we've never had in history a period where people were living with the aging process, this many people. So a lot of our medicine actually hasn't been in this population. Yeah. And yet, being physicians, and I close, we have a certain arrogance around what we think we know because we're very, we believe to be very rigorous. But the truth is, it doesn't matter how rigorous we were. If we haven't actually studied a lot of what's going on in patients who are aging, then we don't know. We're discovering, and we're in that process. Now, one thing we have done, and this is, like I said, the part that I advocate a lot around, is frailty is a way of measuring physiological age in a way, and that's and that is kind of sorting itself out right now, and that's thanks to a lot of work by Ken Rockwood and Linda Fried, who've moved this forward, But the next question is, okay, now that you identify frailty, then what? And I think that the reason why I'm here today is because these geriatric co-managements, and Monty, you demonstrated with a lot of the work that you've been happening in the UK as well, and the British Geriatric Society and the Fit for Frailty and everything they're doing there, is that we're discovering what appropriate management of frail patients are. But I'm happy to report that on all fronts, everywhere in the world that we've looked, by bringing in this kind of thoughtful management based on this understanding of aging, we've been able to reduce delirium, improve quality of function and mortality and all these other things. But one of the biggest, I think, hardest challenges for geriatricians is that medicine is based on diseases. Mm-hmm. And one of the things I like to say is that aging is not a disease because it has 100% incidence, and by definition it doesn't qualify. The other element that I think is challenging and it's difficult for the medical community is a lot of the research arm has been based on diseases as well. Yeah. And no disease will have such an influx of patients or members, people who are going to be integrating these issues into their lives. So I think the time frame of the system of research also needs to be adjusted a little bit for our geriatric patients. And then the third element is just the potential of this population is another one that I think people dismiss and what they're able to do.
Yeah, absolutely.
Quite often, I work mainly on intensive care. We often have alleged evidence-based discussions. We call ourselves evidence-based perioperative medicine. It's part of the strap line here. As you're referring to, use of drugs, for example, they're almost never tested on the elderly patients.
That's right.
They're excluded. So you have an 85-year-old, and they're on a sack full of different coloured tablets. Yeah. I mean, do you spend more time starting tablets or stopping tablets?
Stopping tablets. Yeah. The main reason is twofold. The first is, like you said, no one's actually studied polypharmacy in this way. Like, all these things have been done in people with disease-based again. Mm-hmm. But the other thing is there's a really good wealth of literature in geriatrics on the effect of polypharmacy itself. And the first thing people say is, well, certainly it can't be these meds. But the funny thing is the polypharmacy literature actually identifies that it's really just a number of
all
medications.
It's
all of them. It's not. It doesn't necessarily mean, and the thing is, you speak to the cardiologist, says, well, my meds actually matter, and then well, no, my meds actually matter, and every specialist thinks that their meds are the ones that actually are making the difference. And the truth is the sum of the meds is causing more harm than I think the benefit is. So I'm going to have to give a plug for another colleague of mine, Dae Kim, who works with pharmacoepidemiology and frailty, and he's reanalyzing a lot of the outcomes in pharmaceutical outcomes based on frailty. And you'd be surprised that what's wonderful about that is you actually discover the things that are helpful in frail patients and then the stuff that actually isn't, and how their side effect profiles can change so much as your physiology changes.
And it's you've been on the drug for 30 years. And you were being treated for hypertension, for example, and now you have no blood pressure. Yeah. But you're still getting up and take the tablets every morning.
And people are surprised why you're...
and obviously the obvious part is if you've been on something for 30 years, who knows what's accumulated?
Yeah.
Like I mean, truly and honestly, who can put their hand on their heart and say they know exactly every metabolite that every medication is producing? Because at the end of the day, it's an active component. Yeah. And then the other area that's interesting is maybe there needs to be different prescription patterns that you may only need. You mean like maybe 2-year bursts of something and then a 3-year holiday. I mean, who knows? Yeah,
we're getting bombed by the people
closing
down.
Now they're closing
all
down.
that banging in the background is understandably very enthusiastic, and the hints are getting stronger to get us out of here.
They are.
If people listening want to know more about frailty and judging frailty, you gave a fantastic lecture about it. Where's the best place to look at the moment for a quick update?
I would actually make a plug for the Fit for Frailty, the British Geriatric Society website.
Excellent.
I really would. I think they probably have some of the most comprehensive website around this with the best idea around it.
Brilliant. So we'll get that in the show notes.
We are, absolutely. Well, thank you so much for sitting down with us. I wish we'd have more time
Well, hopefully we will sit down again for a much longer conversation.
That would be great. Yes,
I was just
very opinionated on a number of things.
Well, I love it. Your enthusiasm and passion, those are the people that we are definitely drawn to. So thank you so much for a wonderful presentation, for sitting down with us, and we look forward to chatting with you again soon.
Thank you.
All right,
thank
cheers.
You for having me.
Thank
Bye-bye.
you so much.
Top Med Talk. Nick Majorison here. Thanks for listening to Top Med Talk. Now all you need to do is find us on social media. We can be friends on Facebook. We can follow each other on Twitter. We can hang out on Instagram, or we can even gorp at each other on YouTube. Get onto your social media platform, whichever your favourite is, and you're likely to find Top Med Talk there. Whilst you're at it, make sure you've subscribed to this podcast so you never ever miss an episode. Helps us enormously if you do that, by the way. And check out the website, topmedtalk.com. On there you can find the email updates where we update you as to what we're doing each week. And whilst you're online, whilst you're doing your thing on the internet, I highly recommend you download all of the podcasts that we've put out here on Top Med Talk. We do an enormous amount of material here. A lot of it is incredibly valuable and, of course, will be in the future. So I just recommend you download the entire back catalogue if you could. Helps us out if you do that as well. And check out edpom.org/meetings, because if you go on there, you can find out where we're recording and what we're doing, because we go to the big meetings, the EdPom meetings. You may have noticed most of our material comes from some of these wonderful conferences that are organised by evidence-based perioperative medicine. So EdPom, ebpom.org/meetings. Get yourself on there, and why not check out the Dallas Masters course, a Perioperative Care Practicum. Hopefully I'll see you there.